Welcome to the Drugstore News Continuing Education webinar, Point of Care Testing Updates for the Pharmacy Technician. My name is Renee Phillips and I'll be your moderator. Our speaker that's setting in for our speaker that we were supposed to have today is Nancy Lyons, and we appreciate her taking the time out of her busy schedule to do the presentation for you. She is the Director of Continuing Education and Clinical Content with Drugstore News. Ms. Lyons received her bachelor's degree in pharmacy from Butler University and a master's of business administration degree from Keller Graduate School. Additionally, Ms. Lyons is a certified diabetes educator. Now, prior to her current position, Ms. Lyons was a scientific advisor in global medical and scientific affairs at Roche Diabetes Care and held numerous leadership positions in clinical programs department for Albertsons and SuperValu pharmacies. During her time at Albertsons and SuperValu, she led the National Diabetes Care Program, implemented a national point-of-care screening program, managed clinical training, and served as clinical preceptor, site coordinator, and residency director for Albertsons SuperValu Community Pharmacy Residency Program, partnered with multiple universities. Her areas of interest include diabetes education, wellness initiatives, and the development of sustainable, innovative practice modules. I do want to disclose that Ms. Nancy Lyons does not have any actual or potential conflicts of interest in relation to this CPA activity. And now, Ms. Lyons.
Great. Thank you so much, Renee. And thank you all for joining. I see we have nearly 200 of you on the phone today, so I'm very pleased to be able to talk to you about a subject that's near and dear to my heart from my time spent in community pharmacy, and that's the point of care testing. Specifically for the role of the technician. As we're going to talk over the next hour, I think each of you have a critical role in making this be part of the business model of your pharmacy. So if you're not currently involved in point-of-care testing at your pharmacies, using the labor model that encourages as much implementation by the community pharmacist, it makes it a much easier sell to your administrators. So let's just jump right in with some of the learning objectives. At this point, the things that I want to make sure that you all walk away with today are to recognize how point-of-care testing, the screening tests differ from diagnostic testing, and we'll be clear with that differentiation to make sure that we're not going to a diagnosis information to the patient just because of a screening result that would be obtained in your pharmacy. We'll also describe how point-of-care screening tests can be used in community pharmacy as part of an innovative practice model. And then finally, we will also describe the role, the important role that you play as a pharmacy technician when performing various functions of the point of care screening test. Again, recognizing that not all state laws may allow the pharmacy technician to have hands-on with the actual collection process, but there are multiple roles that the pharmacy technician can take here, and we will be talking about those. See if I can get the slide to move forward there. There we go. So to set the stage before we get too much into the actual test, and we will spend some time about the various collection areas that a point-of-care screening test can be performed, I'd like to set the stage with healthcare reform. It seems like any media that you might be exposed to, so whether that be the radio, television, any digital media that's coming in on your phone or on an internet resource today is talking something about healthcare reform. Nowadays it usually has a political spin to it, and we're going to steer clear of that. So no matter what you think about the appropriateness of the Affordable Care Act, the first point on the slide here is clear that more Americans have access to health care through the exchanges and the ability for them to purchase that health care coverage. And with the penalties and all the things that are coming in, now is a big enrollment period that you may have heard in your pharmacies, more and more people signing up. What is kind of embedded within that, and some things that are key that are going to set the stage and build the case, again, the business case for point-of-care testing at pharmacies is the second point on the slide here, and that is the insufficient healthcare resources. Since the beginning, when healthcare reform was being penned in Congress, before it ever got to a passing stage, analysts have been looking at what it was going to mean to the country to have so many more bodies within the healthcare system with coverage. And the insufficient resources have been clear since the beginning. Just to give you a picture of some of the statistics, the Health Resources and Services Administration were one of the first to publish, and they have determined that today about 20% of Americans live in an area with insufficient PCP. In this case, we're talking about a primary care provider. So to translate that a little further, the family practice doctor or the internist that your patients will be seeing. So already 1/5 of the population don't have enough doctors to meet the needs of their health care. Additionally, about 16% of Americans live in an area that don't have enough dentists, and 30% live in an area with insufficient mental health providers. So again, since the legislation was being passed, schools have done more to kind of beef that up, but they are anticipating shortages. One of the biggest shortages was published by the American Medical Colleges, Association, of American Medical Colleges, and they are estimating that by 2020, so not that far into the future, there will be a shortage of at least 45,000 primary care providers or doctors in the United States. So to think about that, as the population continues to age, we have the baby boomers and others getting into the age groups that are going to have more potential for chronic illnesses and even acute illnesses. We're not going to have enough providers, and it's only going to get worse as time goes on. That number does take into effect the people in medical school or preparing to go to medical school, as well as retirements that they're anticipating. Some more background, again, kind of building our case for point-of-care testing in the pharmacy. Estimates exist today that about 225,000 active pharmacists were in the United States in 2010. Those censuses are only pulled every so often, so that is the most recent data that we could find for you. When you compare that to the 208,000 primary care physicians currently, or in 2010, 30,000 physician assistants, and 56,000 nurse practitioners, our picture that we painted on the last slide continues to be an issue for us. Pharmacists, again, are at a key place not only because of the number of people or number of practitioners that you're all working with in your stores, but also just the locations. And 59,000 to 67,000, depending on which statistic you believe and which growth model that you believe, with all of the retailers and community pharmacies across the country are in existence. A statistic that was published in 2012 by the National Association of Chain Drug Stores provided an estimate that over 90% of Americans live within 2 miles of a pharmacy. That stat was actually part of some of the work that your pharmacist may have been talking about with provider status, being for your pharmacist being able to bill Medicare and other insurance entities directly. So all of these stats are relatively recent to be able to build that case to let us come in and help the struggling culture of not having enough providers, even though they have the financial coverage. So why point-of-care testing, and what is point-of-care testing and the screening? As Renee mentioned in my introduction, I've been pretty close to point-of-care screening in community pharmacy settings for some time. And the actual definition are tests designed to be used at or near the site where a patient is located that doesn't necessarily require permanent dedicated space, and that are performed outside of the laboratory. So thinking of a simplistic example, you all may have had to go through drug testing as part of your pre-employment process. It is unlikely that you went to the actual laboratory where the results were read. You more than likely went to a center that was contracted to do point-of-care screening to collect that urine sample for you and send it away to a lab for analysis and approval for you to get your job in the pharmacy. Those point-of-care testing locations are growing, and they're governed by something called the Clinical Laboratory Improvements Amendment that we're not going to go into detail here, but later on when I talk about some of the requirements about documentation and record keeping, I will mention the CLIA, which stands for that Clinical Laboratory Improvements Amendment. And essentially, it gave the ability for sites like those drug testing facilities all the way to your pharmacy to perform tests that have been approved to be conducted outside of a laboratory, if that makes sense. Now, another key point that we want to talk about was point-of-care screening. And a key point, if you're ever recommending tests to patients, is that a test performed in a pharmacy is always referred to as a screening test and never a diagnostic test. And the key things to keep in your head and to remember about those will help to reinforce that are the sheer numbers of tests available, and then the terms reactive versus positive. To help understand this, I'm going to give you an example. In a bit, we're going to talk about a hepatitis C virus screening test, and I'll walk you through how you'll collect the blood and put it into a testing unit and actually be able to tell the patient if they're reactive for that virus antigen. Those were key words there. We would never tell a patient who screened positive in our pharmacy that they had the hepatitis C virus and needed to go into treatment. We would refer them for further evaluation by their doctor. And then to go back to the numbers game, it's estimated right now for hepatitis C, again in our example, that there are approximately 100,000 patients across the United States that have hepatitis C that do not know it. We wouldn't want to put all of those patients into a diagnostic testing procedure unless they had first taken part in the test that didn't cost as much. So we would want to screen the population. Someone walking into your pharmacy might be at more risk. So we would want to do the test that allow them to be screened less expensively, and then only those patients who screened as a reactive would be going on for that diagnostic test. In most of the states where you're all practicing, only a physician, nurse practitioner, or physician's assistant working under a physician are able to make a diagnosis. Now, there are some exceptions in some states that allow other practitioners, including pharmacists, to diagnose some basic things. But for the majority of the listeners today, only a doctor, nurse practitioner, or a PA can make a diagnosis. A pharmacist can refer to, or a pharmacy can refer to. So point-of-care testing, again, just to have that, this is one of our learning objectives, to have that clear in your head, would never result in a diagnosis at the point-of-care testing location. So to move on, before we get into the actual tests and how they're going to be implemented, I'd like to just review quickly with you the list of diseases that have common point-of-care testing. Again, Renee, during the introduction, mentioned that I used to run a diabetes care education program for one of the chains, and that has been one of the first point-of-care test offerings that was made available. Whole blood sample was pulled from the patient's fingertip through a finger stick with a disposable Lancet, and we were able to run that either through a blood glucose monitor or a device that measured A1C later on, and let the patient know based on some screening criteria whether or not they should be followed up with by a doctor for potential diagnosis in diabetes. With the statistics about the number of people who currently have diabetes and will be having diabetes during their lifetime, it makes a lot of sense to do a very low-cost screening point of care at a convenient location for them, such as someplace that's in their community center within 2 miles of where they live. Cholesterol, another chronic condition that can have some pretty serious healthcare costs, makes a lot of sense to do that screening. Patients who are at risk, who reach a certain age, who potentially have weight issues or other problems, can do a very quick screening test in your pharmacy, find out if their results warrant further follow-up and potentially medication. The hepatitis C and the HIV tests that we're going to talk about, those are slightly different because of the risk to other individuals. That a proper screening not only protects the patient and gets them into better treatment, but potentially could lengthen their life or prevent some cancers and things that could happen with hepatitis C, but also help them to take some more invasive protective measures so that they're not in the position of infecting someone else that's close to them. Those last two on the list here, with influenza and strep throat, those are a little bit outside the bucket that point-of-care testing initially, when it came into the pharmacy, was focusing on. But absolutely, what a wonderful opportunity for some of the states that are doing some innovations with collaboration with physicians in offering the ability for a pharmacist to initiate some simple protocol-based therapy more quickly. Some of those tests could really be a game changer in making sure that the workforce doesn't have delays or is missing valuable workers and people having to take more sick days because there was a delay in treatment. So we'll talk more about those when we get to each of those individual tests. The next piece, and again, this was one of our key learning objectives, so I want to take a few minutes to talk about innovation of practice. And usually we think of anything new that's added to the busy lives that you all hold, taking care of pharmacists. There needs to be a reason behind anything extra that we're asking a technician or a pharmacist to do in a community practice, because you're all already very overwhelmed with all of the legalities and the filing requirements and everything that's necessary to deliver safely and effectively a prescription for a patient. But as we move forward again with healthcare reform, we kind of set the stage with that. There are tremendous opportunities to innovate practice, to change the way community practice impacts all of those patients who aren't going to have access to their primary care provider. Even a nurse practitioner might not be able to see them as quickly as they would like to. So regardless of what your pharmacies already have in place, the two key points I wanted to talk about here are improving screening access for patients who are at risk. There's nobody who sees patients, and they don't think of them as patients when they walk into our stores and community pharmacy, but there's nobody who sees these people as often as anybody who works in a community pharmacy, yourselves at the forefront, those people that are greeting them when they come in and usually taking care of them as they're leaving our stores. With some simple questions, with developing the relationships that pharmacy technicians already have with those patients, you can make them more aware of the screenings that might be applicable to them based on their age or based on the other medical conditions that you know that they have. Getting that early intervention, and if something is reactive in your point of care testing, making sure that the referral goes to the right person is going to save them time, which they're sometimes as busy as you all are in the pharmacy. It helps them to avoid some of the extra steps in the healthcare process. Ultimately, it will save money if we can get somebody who has a need for a diabetes diagnosis diagnosed more quickly. Some of the interventions that they can go on earlier before complications set in save the healthcare system and the patient a great deal of money. And overall, just taking care of things, doing some healthier practices early on improves the patient's quality of life. And that's something that everybody is interested in because it goes back to those other two of saving time and money if we can help with those. So again, even if your pharmacy is only going to do some very simple point-of-care testing or some point-of-care screening, even if you're inviting in others to take care of the CLIA waiver, the community pharmacy and your referrals as one of the members of the healthcare team who knows them best is exceptionally important. The next point is for those pharmacies that are considering stepping up the level of care. Many of you may already be a site where comprehensive medication reviews, CMRs, are being performed, or medication therapy work is being done in some shape or form as either part of a patient-centered medical home, part of a collaboration or an initiative to become a pharmacist coach or something in there. Anytime the pharmacist can have access to relevant, timely data that can guide their recommendations and their therapy decisions or their therapy optimization decisions, it only improves the process. So one of the first things that my previous employer did in that supermarket standalone grocery store chain was once we got the health screening processes working, the pharmacist began using that information to make recommendations to the doctor about changing their lipid medications around, about adjusting their diabetes therapy, and a number of other medication-related issues that before the point-of-care testing was available, we would have to request the results from the laboratory that might not be the newest results, and the doctor may have other information that we didn't. So definitely enhancing those medication therapy management recommendations. With the last two, if you remember that first slide where we talked about the strep testing and the influenza testing, allowing faster medication adjustment and starts. Again, in some areas where practice innovation is such that collaborative practices agreements are in place, and your pharmacist may be able to work with the doctor to follow a protocol and kind of tell them later that the patient came in, had a positive screen for influenza or strep, and start them on a protocol antibiotic. Shortening that period of time, shortening the time that a patient might start an antiviral during flu season is only a win, again, for all of those reasons with quality of life, time, and money savings. So those two key things, again, those of you who are interested in getting something started, add to the business case of getting your pharmacy leadership to allow your pharmacist and you, the technician, to be able to start some of those new practices that are going to not only improve patient care, but add to the bottom line for your store, which gives us all some job security. So let's get into some specifics now about the actual products and how they're collected. Again, some of your states allow, wherever it was possible, we always wanted the pharmacy technician to do as much as they could to keep the pharmacist's time to the things that the pharmacist had to do. So definitely performing a finger stick where possible, doing a collection with some of the other kits that we're going to talk about is always an ideal situation. My examples are going to be only that. They're going to be examples. In no way are there going to be every single kit, every single whole blood kit or test that's available on the market. If your store makes the decision to add point-of-care testing, there'll be a lot of things that go into the equation. including total cost of the product. Your procurement people will most likely be involved. And then when you have the actual product that you will use, you'll want to go into detail in learning the ins and outs of that test, whether or not refrigeration is required, how long it has to be outside of refrigeration before the kit can be used, expiration dates, and all of those things that are typical. Any of you who are managing immunization inventories, you'll be familiar with the processes that you just apply to these products. But again, to move on forward, we're going to talk about these 4 key areas of specimen collection: whole blood, oral fluid, nasal swabs, and throat swabs. And what I will do is talk basics about the collection site, and I'll give you an example or 2 of the kits that are necessary. So with whole blood, if you are in a state that allows the technician to perform whole blood collection, it's always recommended that you complete bloodborne pathogen training separate. And again, we're not going into the details of that, but to make sure that you're protecting yourself and you're fully aware of personal protective equipment. And your various employers will more than likely already have a process in place for that. But when you start doing whole blood collection, you need to pay a lot more attention to the do's and don'ts. And I would recommend reviewing that if you're going to be starting this from scratch. But in general, I want to start by letting the patient know what's going to be happening, especially with a finger stick. Not so much some of the other tests that we're going to talk about. Patients may have a lot of anxiety that's going to hurt. They may jump. They do all sorts of things. So calmly explaining it to them typically helps. Your key focus is to get as adequate of a blood flow supply as possible. So the points that we talked about are instructing the patients to rub their hands together. Excuse me for that. Our other presenter had a bit of a cold, and I think this lesson may be causing that. So give me just one moment. Okay, again, I apologize for that. But blood flow, again, is going to be critical for this. So as the patients are waiting for you to assemble the kit, have them rubbing their hands together to increase the blood flow. If you have the ability to let them wash their hands with warm soapy water, that is recommended, again, to stimulate that blood flow. For yourself then, you will want to make sure that you're washing your hands and putting on gloves, again, as part of your personal protective equipment processes. You will then also have an alcohol swab available to clean whatever site you're going to use the lancet on. Typically, it would be the ring finger or the middle finger to get the best blood flow. After using the alcohol swab, allow the area to dry, and then using a single-use lancet, not a lancet that would that comes to the patient as part of a glucose monitor, but a lancet that can only be used once for infection control. You'll activate that lancet, puncture the skin. In general, the tests are going to require that the first drop of blood is wiped away, and there's a technique where you can rub that firmly away to make sure that that site stays open and you get a good blood flow. It may be necessary, depending on the amount of blood that you need, to squeeze and kind of milk, and it's recommended that you start from the palm to milk all the way down that finger to avoid getting too much interstitial fluid or the fluid around the blood supply to come in. This is a picture then of the technician's a capillary tube that would be used with the Cholestech LDX machine. You can see that that's a pretty healthy drop of blood, usually some of the more invasive tests can take a much bigger drop of blood than patients might be familiar with if they're doing any type of blood sugar testing at home. I mentioned the Colestech LDX. It's probably the most common machine that a community pharmacy would add if they were going to focus on lipid testing or cholesterol testing. All of the different types of cholesterol could be tested on this machine depending on the cartridge that would be purchased. The test also can do A1C and a blood sugar test. So you see on this slide here all of the different supplies that are necessary. The Colestech machine is there in the center. You can see it here. These are the capillary tubes and the plungers that are necessary for the blood collection. There's a slightly better picture of them up here. And then the actual cassette where the blood sample is put on to be able to go into the machine. And then there are a series of optics checks that are necessary to make sure the machine is functioning properly so that you're getting a good result. These are definitely areas of focus for pharmacy technicians, having the supplies, having in-date supplies. We'll talk about that a little bit later when we're sort of wrapping up. But you can see this just adds to all of your inventory management skills, that making sure that the right tests are ready to go whenever they're needed, either for use by you if you're able to do those collections or by the pharmacist. To get a Colestech LDX result, the company focuses on how easy it is. So you're sticking the patient with all of those things that we talked about, getting a good capillary tube fill, applying the blood to the cassette, and then inserting it into the machine. And then in 5 minutes, you get the nice little printout that can go right on the patient's chart information if necessary, back to the prescriber with a recommendation or however your system is using that. Definitely provide it to the patient if you would want to provide them to as a copy. Another one of the whole blood tests, a little bit different than the capillary fill that we just talked about, is that hepatitis C test that I mentioned in the introductory comments. Even though it has in the name OraQuick, the hepatitis C is the chemistry only works currently with blood. So our specimen collection loop would be used in the same way that our capillary tube was before to be able to collect the blood drop that was necessary to be added into the developer solution vial, mixed up fully, and then added the testing device to get the result. And again, so with the hepatitis C test that we're looking at here, it does require a blood specimen, a whole blood specimen. We mentioned at the beginning the difference between a diagnostic and a reactive, and I kind of have already gone through that. But you can see the visual here. Each of these double lines, so the control line and the test line, having a color, and then even if the color is faint, as shown on the right of the screen there, this would be an indication that the HCV test result was reactive and further follow-up was necessary. Again, at the beginning in my comments, we talked about how a reactive test doesn't necessarily mean that the patient has an active hepatitis C condition. In about half of the cases where this protein may already be in place, the patient's immune system was strong enough at the time that the virus may be completely cleared. The protein still exists and still is picked up by the test, but the patient doesn't have active hepatitis and isn't at risk for some of the tumors and things that we think about with that disease. So again, never telling a patient that they have the diagnosis of hepatitis C, because even if the screening test reacts, they need follow-up with a more invasive test that's more costly to make sure what kind of procedures they need to go forward with. So that concluded the blood tests that we're going to talk about here. Obviously, there are other blood-related tests, blood glucose tests. Some of you may have used an A1C cartridge and some of those other tests. Again, always following those manufacturer instructions. We're going to move on now to the oral fluid collection technique. Same thing as we talked about with blood. You need to explain to the patient what's going to happen to them. So when you come at them with a swab and ask them to open their mouth, they understand that you're not going to hurt them. A key point with the ones that are collected from the mouth, you need to read the instructions carefully, but in general, they shouldn't have eaten or had anything to drink, or even use a toothpaste or a mouthwash, or smoked for a period of time prior to the test. Usually it's at least 30 minutes, some maybe an hour, and some may be longer than that. So you'll want to look at those manufacturer recommendations. And if you're the one scheduling the person to come in for the test, giving them that information before they come in, the night before they come in, or when they schedule the test. Again, personal protective equipment, you're going to wash hands, put on gloves. The patient's head needs to be tilted back. Always, whenever you're doing a collection, you're going to hold the collection device in your dominant hand, the one you have the most control over. So if you're right-handed, that would be in your right hand. And then with the other hand, you'll do the manipulation of either holding the patient still or moving the lip, in this case, to get access to the gums to swab them. This just gives you a quick pictorial. So this particular kit, again, is our oral kit. You are essentially rubbing inside on the gum line, so just inside the cheek, all the way around. This shows the upper gum, but then the device would be flipped down to swab the lower gum as well. Once that, and again, you'll notice that this kit is very similar to our hepatitis C kit that requires the blood. This kit, of course, doesn't have the little collector wand that I showed you. This kit just has the swab, and then the solution goes very similarly into the kit. This is a quick 1, 2, 3 step, and in 20 minutes after collection, you'll have either the reactive test here on the left, or the test that properly functions, where the control line went through and no test reagent was seen. So in this particular case, it's an HIV test, and we would want to show that the patient did not have a reaction or was not reactive for HIV based on the kit on the right. We're now to the first testing your knowledge test. And Renee is going to work our quick poll. So I'll read the question first, and then you'll be able to choose that. So which of the following specimen collection techniques is used to perform a point-of-care screening test for HIV?
We'll give it just another moment here. It looks like most of the participants have voted. And it looks like 51% for B and D.
Great, and that means that they were listening. B and D with the specimen collection for the HIV test. And our answer is E. Answers B and D. So oral fluid works with the HIV test, as does whole blood. So we're going to move on to make sure that we're managing time here. The next test that we're going to talk about quickly is a nasal swab technique to ensure that this test is performed adequately. You can see the instructions here on the slide. It's important that the patient does not blow their nose before using the test. And again, tell the patient what's going to happen. This one, as you'll see on our next slide, is a little bit, it appears to be a little bit more invasive because the swab needs to go back into the nasopharyngeal space, and I'll show you what that looks like. But again, the patient's going to tilt their head back, close their eyes, holding that patient's chin steady, and then manipulating the cotton swab straight into the cavity and rotating it to scrape off both mucus and cells. This is what that looks like from a couple different pictures to collect that specimen. Again, it's not going to hurt them, but they may experience some discomfort as you're manipulating there, so you would want to make sure that you were explaining that to them. That collection method is used for the QuickVue influenza A and B test that we had talked about earlier. The quick 1, 2, 3 steps for the QuickVue influenza A and B test are first to activate the solution, and there's a bottle that comes with that. After the cells and mucus have been collected, the swab gets dipped into the vial and is stirred 3 times. You wait about a minute and stir 3 more times, and then insert the testing device. After about 10 minutes, you'll have a result. And these are the methods there, and you'll see the different screenings again with the blue showing that the test functioned properly, and then either a solid red line, a weaker line, or no line to let the patient know if they're screening positively for the influenza A and B, which again could allow your pharmacist to make a recommendation at a minimum to get them started on Tamiflu or some of the other antiviral medications and help them to manage those things more quickly. So optimizing treatment as quickly as possible. The next technique we're going to talk about is the throat swab. A lot of the same techniques exist. You're going to wash your hands. You don't necessarily have to use gloves with this test, although you're protecting yourself with those gloves. So I typically always wear gloves. Ask the patient to tilt their head back, stick their tongue out, and close their eyes. And then you'll use a tongue depressor along with the specimen collection. The next slide allows us to see how that works. Essentially, you're going to be swabbing the tonsillar spaces, so back in the far reaches of the throat. On each side, try not to touch the teeth or the sides of the cheek to get your specimen. That then needs the swab to be inserted in the test kit for everything to be mixed appropriately. The vial actually has the reactant inside the vial and requires kind of a break and shake method, and then the resulting solution being applied to the test kit and waiting for about 5 minutes to get the strep result. Again, the C, the control, means that the test worked, and then whether or not it was reactive for the strep A. Again, allowing your pharmacist to at least make a recommendation to get into the physician, or in some of those areas to be able to get a quicker ability to get some treatment if there's collaborative practice. So we've got another quick testing your knowledge. Which of the following specimen collection techniques is used for influenza testing? So go ahead and make your selections, and Renee will help us see what our results are.
I think they're all getting the hang of these polling questions now. It's going a little faster, so I'm going to go ahead and close the poll, and we have 67% for the nasal swab.
Very good. You all are excellent at measuring that. The nasal swab is correct for influenza. The throat swab would be more for the strep testing. And then the oral fluid was a great guess by the 4% of you, but that one is not currently used for influenza. But thank you very much. We're now, just to reinforce and make sure everybody's on the same page, we're going to play a quick matching game. This one will not allow you to respond, so I'm going to ask that you just kind of mentally make a note of what your answer would be, or write it down to your choice. You're going to kind of quiz yourself and grade your own paper is what we're going to do here. But thinking of our point-of-care screening test that we've talked about in this presentation, and then the site. So practically, if you were going to at least schedule a patient to come in and do one of these tests, what would you need to tell them to do to prepare based on where it was going to be collected? So if it was whole blood, they don't have too much preparation necessary with the exception of some of the cholesterol tests that you would read about. You would want them to wash their hands. If it was oral fluid, they would want to not smoke, eat, or drink for a period of time as indicated on the test. For nasal swab, we want them to not have cleared out their nose completely when they come in. And then for throat swab, it's typically similar to what you'll see with the oral fluid, where there may be some eating, drinking, or smoking limitations. So for diabetes and cholesterol, I would like for you to write down which of the areas, whole blood, oral fluid, nasal swab, or throat swab, that the patient would need to be prepared for during the screening process. Because you were so quick on the last one and because I can't see, I'm going to go ahead and move through these fairly quickly. So diabetes and cholesterol would be whole blood. And again, those are the most common, earliest ones that we had available, and there hasn't been a lot of change in the way that that was collected. So for strep throat, which of the areas are you thinking? For strep throat, it's going to be the throat swab. That one was fairly easy if you look for those keywords. Hepatitis C is going to be a little tricky. I'm sure you all can get it. Hepatitis C, even though it had aura in the word, was whole blood. HIV, another oral one, could be oral fluid or whole blood, and we already had a question reinforcing that you all did very well on. But HIV could be either, depending on what the patient was more comfortable with. And then our influenza was the nasal swab. So I'm going to put up all the lovely lines going every which way and every which direction. But again, for your focus, focusing on what the patient would need to do to complete the test and what they would need to be prepared for when they came in to meet with either you or your pharmacist. So just to bring home, we've gone fairly quickly through a number of tests, and I want to make sure I'm leaving some time for questions and the things Renee needs to handle so you can get your credit. But if you'll indulge me with just a couple more minutes with reinforcing your role with point-of-care testing. Again, your state law is going to dictate the level to which you can go forward with doing point-of-care testing. But the business model and the practice model is always going to say that you as a technician should be trained and move forward to do as much as you can to deliver as much patient care as you're able to do to allow the pharmacist to maximize the time he or she is spending making recommendations. So at a minimum, you're the front line. You're the one who can actively market and refer patients who are in need of screening. Your pharmacist can help you with your targets for the various conditions. And we didn't cover that in this lesson. However, thinking about patients who may be at greater risk, especially for diabetes, those are easy ones to spot, and then looking at some of the other medications that patients might be on, and just making them aware that the tests are available in your stores. Again, performing and assisting the pharmacist with the paperwork and record keeping. At a minimum, you need to make sure that the results are getting adequately recorded and placed where you're keeping them, either in the patient's record electronically, sharing them with the patient, or sharing them with the patient's other healthcare team members, that you can easily own that process. Ordering, stocking, and preparing the screening supplies, we've already talked about that. Just adding this into everything else that you do to keep our pharmacies running as well as they do. These have some idiosyncratic issues related to expiration dates and time out of the refrigerator sometimes. Becoming aware of those and then just making sure that we always have in-date, ready-to-be-used supplies. I mentioned briefly the CLIA, the Clinical Laboratory Improvements Amendments requirement. Once a store has one of those, there are audits that can take place by the government agency that basically go back to whether or not you're performing the manufacturer recommended updates and upkeep of the device or the machine that you're using to collect the results. So there are logs, and your store will have its own process, but making sure that you're complying with those and keeping the quality assurance and making sure that the checks are being performed. And then specimen collection. And again, if your state law allows it, get in there, learn how to do it, and become your patient's advocates for that. One more testing your knowledge question, and then we will move on to your question. For which of the following specimen collection techniques is used to perform point-of-care testing for strep throat?
Really quick one on that one. We have 95% for the throat swab.
Very good. That one was an easy one, but we wanted to leave you with total confidence. Very good. Now we are to the question phase. One of the questions that has come in is related to knowing which test to market and to use in your pharmacy locations, and if I had any recommendations for how to get started. Again, I sort of mentioned it during the presentation. You'll always want to work the business case first, and knowing your audience. If you're in a population that's an older population, you may want to focus more on the diabetes and the lipids testing, rather than perhaps some of the influenza testing, which typically would be marketed for a younger class, or a class that had more people who are having difficulty getting to the physician outside of the regular workday. A retired class wouldn't have those same conditions, those same responsibilities. In either case, you need to look at any capital outlay that would be necessary. So your store team will decide whether or not they could afford a ColesTech LDX and all of the equipment and supplies that might expire to make sure that your marketing plan is there. But definitely a great question, you know, a forward-thinking question that you want to work with your store teams to make sure that you're doing the right ones there. I know we're running really short on time, but another question that came in related to the CLIA waivers and how those happen. A CLIA waiver is actually issued by a government agency that I talked about before. While it's a national organization, each state handles the application process, and there are various requirements depending on your state based on whether or not a laboratory director is needed, and then the credential. In some states, a physician has to be the laboratory director, and in other states, your pharmacy manager could be the laboratory director. It has an annual fee. It has annual processes for keeping the equipment up to date, but then once you have that, you're able to administer tests that have received the CLIA waiver through the national laboratory processes. Oh, and there's another question here about insurance covering the test. It depends, so that question is excellent. I have worked in situations where we've had education provider relationships, and they did pay for the cost of an A1C test administered by our pharmacy. I would say it's probably not as widespread that you could bill it to the patient's healthcare provider, but that would be on a case-by-case basis. In general, the costs of these tests when delivered at retail are usually about the amount of a copayment, and as patients are having more decision power, they're looking at some of those higher deductible plans. A $29.99 cost or a $25 cost in your store is about the same as that. I also see a question about testing on patients under 18. With a patient or somebody who can sign for them, so with a caregiver who's authorized to deliver care, you just need to work with your legal department to make sure that your permission and release form is written correctly, and you're able to do that. Patients are able to buy cholesterol tests and do them at home. There are a number of tests. The HIV test is one of the ones that has a home version. The patients can definitely do those at home. In many cases, the cost may be about the same, but whether or not the skill is present for the patient to be able to do those. I see another one here. The question is from Florida. Are we trying to decrease the responsibility of a primary care provider? As I'm reading the question quickly, it looks like my take on point-of-care testing isn't ever to decrease the responsibility of a primary care provider. If you look at all of the patient-centered medical home models, the doctor needs to be at the center of that. We need the doctor and the patient directing their care and getting the best care that they can, the most effective care that they can. The pharmacist, it's not as much about pharmacist responsibility, but it's at delivering the right information at the right time and most cost effectively. So I'm not sure that I'm answering your question as you posed it correctly. But in general, having the pharmacist be part of the team as appropriate, never superseding the doctor, but definitely increasing access, as we talked about before, to some of those screening tests, and speeding the care delivery process. Never adding an unnecessary level, though, is the goal of point-of-care testing.
Okay, Ms. Lyons, that looks like we're going to have to wrap it up. Well, thank you, Ms. Lyons. We really appreciate you setting in for the Aileen Miranda Wilhelm, who was unable to make the presentation today. Thank you so much for stepping in at the late